Thank you for joining us for today's webinar, Transitioning from Training to Practice, What Don't I Know?, hosted by the ACS Women Surgery Committee. Our moderator today is Dr. Jyoti Chouhan. Dr. Chouhan is an associate professor of urology at Oregon Health and Science University in Portland, Oregon, specializing in the management of cisgender male lower urinary tract reconstruction and gender-affirming surgeries. She is also the OHSU Medical Director of Clinical Documentation and Integrity, which focuses on inpatient documentation and coding. Dr. Chouhan's clinical research focuses on prescription drug use in urology and gender-affirming surgery outcomes. Prior to her career as a physician, she was a hospital pharmacist. Dr. Chouhan completed a fellowship in male urologic reconstruction at Wake Forest Medical Center after a urologic residency training at SUNY Downstate Medical Center. Dr. Chouhan is a member of several professional organizations, including the American Urological Association, the Society of Genitourinary Reconstructive Surgeons, and the American College of Surgeons. Dr. Chouhan, thank you for moderating today.
Thank you, Jenny. So I just want to thank everyone for joining us today for our conversation on the topic entitled Transitioning from Training to Practice, What Don't I Know? We are joined today by three panelists, Doctors Tiffany Sinclair, Cheyenne Sonntag, and Irlna Trantchou. I'm going to be introducing each one of these well-accomplished women. So Dr. Sinclair is a breast and endocrine surgeon in private practice in San Diego, California. She has previously worked as a locum tenens acute care and trauma surgeon and as a general surgeon for Kaiser Permanente in Los Angeles, California. Dr. Sinclair received her medical degree from the Perelman School of Medicine at the University of Pennsylvania and completed her residency at Stanford University with a fellowship in endocrine surgery at Cleveland Clinic in Cleveland, Ohio. She has been a member of the American College of Surgeons Women in Surgery Committee since 2017 and currently serves as the chair of the Personal Empowerment Subcommittee. Dr. Cheyenne Sonntag is an acute care surgeon and clinical assistant professor at Stanford, where she has recently accepted the role of associate director for the Emergency General Surgery Service. She is also a major in the U.S. Army Reserves. She is board certified in both general surgery and surgical critical care and completed her surgical residency at Penn State Health with her surgical critical care and AAST acute care surgery fellowships at UCSF and San Francisco General Hospital. Dr. Irlna Trantchou is a colorectal surgeon in northwestern Arkansas. Her main focus and area of expertise is minimally invasive surgery and robotic surgery. She holds a master's degree in robotic surgery certification. Dr. Trantchou received her MD degree from UMDNJ Robert Wood Johnson Medical School and completed residency at New York Medical Center, Westchester Medical Center. She then went on to complete fellowships in colorectal and minimally invasive surgery at the University of Texas at Houston and St. Vincent Hospital Allegheny Network. Dr. Trantchou is board certified in general surgery and colorectal surgery. Dr. Trantchou is committed to changing the statistics of women of color in the field of surgery and increasing awareness of the benefit of preventative medicine, like getting colonoscopies, in the minority communities of Northwest Arkansas. Other areas of her professional interests include colorectal cancer care and management, and the importance of pelvic floor management in women's health. So thank you all for being with us today, and we're going to get started with the panel. And I'm going to start with Dr. Sonntag. So when you first started practice, how did you seek mentorship in your initial years? I think a lot of us, when we first start, aren't quite sure the path to getting on top of our quick practice as quickly and maybe with as least stress as possible, and mentorship is a way to certainly try to help us with that process. So if you could share your thoughts on that, that'd be great.
Yeah, and notably, I didn't join any of my training programs, so I am removed from some of those mentors and mentorships that I cultivated during my residency and fellowship. I think the first place to start is to keep those going. Keep those close relationships with those you trained with people who are maybe years ahead of you in the fellowship or in your residency, who are now in the similar field as you, or in those fields you might rely on for advice or consultation. I know I've kept a collection of faculty, former residents, and peers through fellowship who are now near peers or formal mentors and continue to be, that would pick up the phone at 2 a.m. if I needed them. And so I would definitely say continue to cultivate what you have. Look at the people around you and really do find those near peer, especially when you start at a new practice or a new academic institution. Look for those who are in a cohort class, you're maybe one year ahead of you in this cycle, who have been around long enough to know where the bathrooms are, but also maybe the ins and outs of getting your case up on the OR board list. What sort of practice tips do they have to navigate the political politics of where you currently are located, because it's different everywhere you go. Look at finding formal mentorship. That's the biggest part to keep in mind as well, is those mentors that used to pass in your hallways as a resident or a fellow, now they're out of touch. They're a phone call away. They're not at your institution. You actually need to set up formal mentorship meetings. Get them on schedules, give them agendas, let the mentors know what it is you want from them, because I don't think any one of us finds everything we need in one other person. So find that person who has that great work-life balance that you want to emulate, and tell them that you want a quarterly meeting to touch base on how that is working out for you, and specifically ask about that and if they're willing to play that role. Find someone whose clinical practice you really admire, who can setting up, making sure your case cards are correct, and some of the smaller onboarding details, in addition to making sure that you're up with PMGs, making sure that you're keeping up with your techniques and skills, and serve maybe as a surgical coach. And then, specifically reach out and get someone specifically maybe in your area of education or research who does the type of work you do. And they may not even be a physician. They might be someone who's actually just in academics. But the important thing is to get those meetings scheduled, set up the cadence, and remember that as the mentee, if they accept that mentorship role, it's on you to bring the agenda. And as someone who does mentoring now, I really appreciate it when someone sends me an email in advance and says, hey, we have our meeting next week. Here are the things I want to go over. Or this is where I'm struggling and I could really appreciate help or resources. Because now I can take a little extra time before we meet and I can pull up those resources. I can query friends. Like, I'm not super into bench research, but if that's the way they want to take their career, I have time to get them resources in my colleagues who might serve as better mentors in that topic. And so, it is about asking, it is about reaching out. It is about utilizing what you have. You're all here on an ACS webinar. ACS has incredible resources, from the actual formal YFA mentorship program, which we'll drop a link in shortly. As soon as I finish talking, I'll send the link. Please get involved. You're able to meet people in your near peer group or formal mentor groups. Organizations like East or SAGES, they have their own mentorship as well for your specific subspecialty. Or get involved with those of you who are not yet YFA. ACS, the RAS institution still holds you, and you still have the associate fellow group there. We will take you. I am currently chairing that committee, and we were specifically working on forming mentor groups and connecting people with mentors within their fields. So if you're looking for mentorship and run out of places to look, please, I'll drop the link for that as well. Shoot us an email, join our meetings, and tell us what you want, and we'll help you get there.
Can I ask Dr. Trantchou and Sinclair, did either of you have an initial practice where you had a formalized mentor structure? We started that in our own department about 5 years ago, and it was very structured with specific questions that needed to be addressed at certain time points. Is that something that was available to you? Do you feel like you would have benefited from something like that?
Okay. Yeah. I actually just saw one of the reasons why I started at where I started, which is not where I currently am, was because I wanted mentorship. So I started with a group that was bigger. It was more seasoned surgeons. And I wanted to be able to have a second surgeon. So it wasn't regimented. It wasn't specific. It was really, I sought that mentorship, and it was kind of like we would meet occasionally over coffee. So it wasn't structured, but it would have been nice. That's actually a really great idea, I think.
I have to echo Dr. Trantchou. When you're looking for that first job, for those of you who haven't already landed in it, look for that mentorship. It's something that I also looked for when I was on the job search, and I was really grateful to find a variance of practice. It wasn't a practice group of all young surgeons, and so there were people that you could reach out to within your group.
Yeah, I would say that I started at Kaiser, there was a department of 8 surgeons. And so we did not have a formal mentorship program because there was always someone available. My most complex cases, I had a second MD available to help me. It was a great first job, in that I felt I had a ton of informal support to sort of develop my practice as a new surgeon. So regardless of what the formality is, definitely having that support network in whatever form is super important when you're starting.
Totally agree with all those comments. I'm going to ask the next question to Dr. Sinclair, which is, from an operating room standpoint, I think one of the hardest things as a young surgeon is to become independent and confident in the operating room. So what did you feel like were the biggest lessons you learned early on that you feel like maybe you wish someone would have taught you or told you, or maybe it's just something we all have to go through that is just worth hearing?
Yeah. So I thought of 3 things. First and foremost, trust your training. You have spent 5 to maybe even 10 years in surgical training plus medical school. You are prepared for this. You have done so many cases. You really are well-trained and prepared to start your practice. And it may not feel like that. It feels super scary, but in the moments that you are feeling doubt, I know myself included, a lot of us experience imposter syndrome. I think that's one of the very common threads of surgeons starting practice, but you are prepared, you can do it, and you just have to remind yourself there are people there to support you, and you can. One of the things that I felt that helped me a lot was developing a consistent routine. So when you are in training, you may work with a lot of surgeons, you are taught a lot of different ways to do things. But when you get yourself into a tricky situation in the operating room, you're into bleeding, or it's just a difficult dissection, having a routine, having steps to fall back on, knowing where your equipment is, having your setup always be the same, having that sort of consistent step-by-step thought in your brain is what you have to rely on when you are in those tricky situations. So when you're first starting out, try different things, figure out what's going to work for you so that you can really develop your patterns and stick to those whenever you find yourself in trouble. I think the third thing that you will hear over and over and over again is have an extremely low threshold to ask for help. It's hard to start surgical practice, no matter who you are, what field you're in. It's scary and challenging to be a new surgeon outside of training. So ask for help, rely on whoever's around you, senior staff members. Everybody has been in your shoes. Everybody knows what that's like. So it is absolutely not a sign of weakness. It is not proving yourself if you can do it on your own. Even if you're just like, hey, I know, I feel like I'm doing this. I feel pretty confident that this is the right thing, but hey, maybe just double check and make sure. Just having someone to validate you, I think goes a long way. So what I always tell myself and the students and other people that I've trained is the worst thing that can happen if you ask for help is that you feel worried about yourself, or you worry what someone else is going to think of you, or that that person is annoyed. The worst thing that can happen is if you don't ask for help and you really need it, is that you could have a bad outcome from your patient. So if you're ever questioning whether or not to reach out, just remind yourself about that.
Those are all great points. I feel like I'm reliving my early years in practice with those wise words. And I think just the admission of what we all feel is very validating to younger surgeons, that, what you're feeling now, we've all felt, and we all get through it, but not without, almost a village to help us. So, Cassie, Irlna, any other tips or lessons you feel like that you could add on?
The only couple of things that I was thinking about as you were talking was definitely the pattern thing. So I always set my cases, the more pattern sometimes is also to try to get me in the mood and get me started to think about the case. The way I drape, I have a very specific way I drape, is bottom, top, side to side. My nurses really laugh at me. But while I'm doing that exercise every time is giving my time for myself to kind of sort of settle in and get into the case. That's a really good technique that I've figured helps me. And I started doing it early on because it helped me sort of really calm my nerves and get ready for the case. The other thing I was going to say is be comfortable being uncomfortable. It's just, you're going to be uncomfortable. You're starting off, you're just not sure. The planes just look different when it's you and it's just you. The cases are more complex. No patient ever reads the book in your first few years. So just be comfortable being uncomfortable, because that's just going to happen. And then the last thing that I was going to add is always debrief after a case. So When I started practice, I really wanted to grow my robotic practice. So after every case, I would record myself and review my cases. Now I record for teaching purposes, but I really started reviewing my cases, and that really teaches you so much more. Even if you're not doing a robotic case, in my case, open cases, anorectal cases, just go through the steps in your head. Think about what you did, what you could have done better, where you had a little bit of the hiccup, and just kind of go through the steps again. And every single time, I feel like I learned a bigger lesson for the next case.
I have to sort of echo what Dr. Trantchou said. I do keep a case log, and after every case, I'll write down, 'cause sometimes I'm trialing new pieces of equipment, or they pulled my partner's case card because I hadn't done that case there yet. And so acute care trauma, they will pull whatever card of whoever's on top, and you'll say, "Oh, I like this, I didn't like this" on their case, and sort of cultivate my own. Um, and going through the steps of the operation again, and where was I awkward? And just as much you have to know that, get comfortable being uncomfortable. Also know you're going to feel awkward. There are going to be body positions. You're going to not set your book Walter right. You're going to be operating on your head and be like, there's got to be a more ergonomic way to do this. Don't be afraid to call in your partners for help. They may not scrub. They might just coach you. Like I've come in and been like, hey, I'm difficult exposing. I'm having issue getting this. And within 2 seconds, they kind of looked at the field, repositioned me, and had me move a couple things. And it was like, oh, night and day. And so, take use of the knowledge that's there. It's not a weakness to ask for a second set of eyes. I would say if it's a more complex case that maybe you haven't done as frequently, or it's been a while since you've done, it's absolutely okay to check a partner before you go in and be like, hey, I'm going into this thing. It's gonna be a 4 or 5 hour case. I may ask for a second set of eyes. Would you be cool if I gave you a call? And I think any healthy situation that you're in, your partner would be, yeah, I'm happy to stop by and lay eyes, or just check in on you. Hey, it's been 7 hours now and you're still in that case. You okay? You need any help? Is there any advice I can give? And so really utilize all of your resources. Take notes on your cases, take notes on equipment that you liked or didn't like, setups you liked, you didn't like. Um, that's the biggest advice that I can give, and never be afraid to ask for that assistance or that help. It doesn't show weakness. I think it shows courage and character, that you're looking out for the best of your patient. If you're not sure you found the right tissue plane, you've been struggling for a while, that second set of eyes is useful.
I think all that great conversation segues into another really important surgical topic that I think is getting more national coverage on, at least in urology, and that is, how do we personally manage our complications? And I'm not talking about how do we, clinically manage a complication. I'm asking more, how do we personally navigate the emotions that happen when we transition from a resident to attending and have to take responsibility for a complication? So I'm going to give this one to Dr. Trantchou. What advice would you give about what can be sometimes an emotional roller coaster that happens when you have a surgical complication as a new surgeon?
It sucks. It sucks. Having a complication as a surgeon, as a young surgeon, is probably one of the most challenging things that I've had to learn in my career, which is how to emotionally handle it. Because the clinical handling of it, we've learned it. We've spent so long learning it. It's the emotional part of it that you don't quite think about how it's going to affect you, right? What I'm talking about is the crippling effect of what a complication does to your mental for the next case, the next similar case that you're going to do, and the not being able to sleep at night, being able to go into my kids' after school activity while I'm thinking about that patient. I still remember every one of my complications. I certainly remember my first complication. I think that the biggest thing that I've learned, really, the first thing is give yourself grace. I mean, that's just the very first thing. We all have complications. The best surgeons have complications. Everybody has complications. I think that the first thing is to give yourself grace, that having a complication does not equal being a bad surgeon, doesn't equal being a sucky surgeon. I think that's the first lesson that I had to teach myself, was to give myself grace. The second lesson that I had to learn was being honest with the patients. I think that to some extent, with the medical legal world, it can get a little bit tricky sometimes, wanting to not take on the blame, not wanting to be honest sometimes, or at least being honest in a tricky way. what I've always experienced is that when people genuinely feel that this was a complication, as in you didn't cut any corners, you didn't do anything outrageously wrong, and this was truly something that happened, most people just recognize that you're trying to help them and this just happened. So I think that being honest with patients has always made my complications or my patients, I feel like I get closer with them during that time, just because, they know that I'm there. They know that I am honest with, this happened to you. I'm not happy this happened. Now we just got to focus on fixing it. So being honest with patient is another lesson that I really had to learn. And really, the other lesson is this is another opportunity to ask for help on how others manage the complication that you went through, right? Because it's, when you go through something and you have a complication that happened, if you phone a mentor, another colleague, a friend in the field, and they're like, oh yeah, that happened to me last year. Oh yeah, that happened to me 2 years ago. It just kind of gives you a little bit of assurance that you're not the only one. So that's always, that goes a long way. And then the last thing that I will say is that recognize that a complication is an emotional trauma. And as being an emotional trauma, it will take time to be processed, right? So we're surgeons. We're supposed to be tough. We're supposed to be nothing affects us and just go boom, 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 boom. When you have a complication, acknowledging that this was a trauma that happened, and someone told me this the other day, is that the surgeon is the second victim after having a complication, because it really makes you question yourself, your skills, your ability to be this amazing field, to do this amazing thing that we do. So really recognizing that, okay, you know what, this is a trauma. I need time to process it. And whatever that means for you. For me, it means that I'm going to have a whole month of having really bad reflux. So I got to pump up on my Prilosec. For me, it means that I need some time to recluse myself and think about the case over and over and over again. For me, I need to talk it out. I mean, everybody has different way, but the acknowledgement of this is a trauma, this is going to affect things, this is going to affect me, I'm going to process it so I can move forward, I think is an important lesson.
Those were all fantastic points that I think all four of us can feel like we've lived through and are still things that we abide by today, even being past, what some might consider being an early career surgeon. Tiffany, Cassie, any other, personal words of wisdom?
Yeah, sure.
Go ahead,
I would
Tiffany.
say one of my favorite mantras, and I'll give Dr. Sonntag in a second, I know we both want to chime in, is that if you don't have any complications, you're not operating enough. It happens. If you are a surgeon, if you are doing cases, you will have complications. It happens to everybody. And so just accepting that fact, and as Dr. Trantchou said, giving yourself grace, and then just moving on to the next thing is, how do I process it? That's what you want to focus on, not the fact that it happened to you, because it will. And that's just a fact of our lives. That's what we have signed up for by choosing this profession. The other thing that was important for me as a new surgeon was trying to figure out what I could take away from whatever happened to prevent that from ever happening again. And sometimes there's nothing that you could have done, but a lot of times it's something little. I could have had better exposure. I could have called for help earlier, whatever it is, just kind of, you don't want to ruminate too much, but I think it is important to kind of go through the steps that happened that led to that outcome and think about the things that you can learn and grow to really help the next patient get through that better or prevent that from happening again.
Cassie?
100% agree. I think we can't overstate just the catharsis and how healing it can be to actually see that patient though and say the words, "I'm sorry that this happened." Because I think we sit in fear. We sit in fear of being on the M&Ms. We sit in fear of being singled out as being the only person complication. We're not the only ones that the complications are happening to, but that patient is the one this complication happened to. And I think all of us are such conscientious individuals that sometimes we fear the legality of saying you're allowed to say, "I'm sorry that this has happened. And, let's get you through this complication. Let's get through this together. And I'm not going to go anywhere." I think that's very important. And then know that there are some great models out there in a lot of academic centers. They're starting peer support volunteer groups surrounding complications to allow for debriefing. A third party who wasn't part of the surgical case, who's probably not in your section that you can talk to. There's a lot of great models out there in anesthesia that are being adopted. Stanford has just started a similar program. And I think that if you're at an academic institution or you're not at an academic institution, it's something to look into, maybe being a champion of your own. It's something you can bring to the table and say, hey, it'd be great if we had a peer support group outside of, unless it's a very small practice, find someone else not in your section to talk to about complications, just to be able to unload in a protected manner. And there are ways to get it protected, like an M&M type session. So
perfect. So I think we have time for maybe one more question. We have about 10 minutes before we'll transition to the live Q&A. But I'm going to start with Cassie on this one and then open it up to the other panelists. But in academic medicine or not, I think it is difficult for a new surgeon to have boundaries, both at home and at the office, to the point where one of those things can significantly impact the other. And from a work standpoint, how did you work to create boundaries around your clinical time to help protect your personal time? And how did you manage the decision process of when is it appropriate to take on extra work, and when is it okay to say no?
Well, I'll admit, I'm, after a year being at Stanford, finally setting up better boundaries. It took a long time to figure out what my boundaries were. And those conversations, what is and what is not important, they need to involve yourself and the other stakeholders. That's going to be your immediate boss. It's going to be your family at home, right? You have to decide as a unit what's important and what needs prioritization. And then once you've decided, put it on your schedule. It doesn't matter if it's family dinner night, if it's a health appointment, it's I'm just going to the gym, but I know I need that for my sustainability and prevention of burnout. Put it on your schedule, because if it's scheduled, other people will respect it. I don't put everything as an open view on my schedule, so you can't see what I'm doing with that hour, but it's on my schedule and me and my admin know if it's green, it's family. Don't mess with family. Like you have people who've been really good about showing me, if you're someone who's working on a project and you need 4 uninterrupted hours to crank through an actual project because you can't work in piecemeal, block it out on your schedule and protect it. That's really the best way to make sure that you don't get encroachment on all sides. But remember, put your personal life on there too. You are no longer the resident, you're no longer the fellow. You have partners who are clinically exceptional, just like you are. They can also cover patients, they can also cover weekends. So if a funeral comes up, if a wedding comes up, if family comes up, family is usually first. And you need to make sure that you do protect yourself from academic needs, from clinical needs, that you're there for them. And so put on your calendar, talk to your partners. You can usually find coverage and get things taken care of. You no longer have to put life on hold to have your clinical practice.
Any other thoughts, Irlna, Tiffany?
Yeah, I think I had to unlearn a lot of the habits that I had developed in residency. We push ourselves to the extreme limit, I feel like, sometimes in training. And I didn't want my adult life to look like what it looked like in training, working 80 hours, never having time for myself or my family. So trying to accept that and finding what those boundaries were for me was super important. This is a silly example, but I got really sick, not COVID, but just a cold. And I was like trying to figure out like how I could go to clinic. And my husband was just like, you should not go. Like, none of those patients are going to die if they do not have their clinic appointment tomorrow. You are sick. You should not go to work. But I'm just kind of so used to pushing through and doing it that it took someone else saying like, no, stop, don't do that. So, listen to your family, listen to those around you, and, take care of yourself.
I love that. That sounds like my husband. But the only thing that I was gonna add on was that also recognizing that boundaries do evolve. I mean, when I started off, my boundaries were not what it is right now. When I started off, I was, I wanted to build a robotic practice. That's all I cared about. And, it was a very honest conversation in my household with my partner about this is what our children is, this is what it's going to look like. Because if I want to build a robust robotic surgery practice, then I know that I'm going to put in the work now, and then in 3 to 4 years, that's going to evolve, right? So the cases are going to take me less time. So I'm going to be able to get home earlier, But in the beginning, I need to put that time so that I get there. So my boundaries have evolved, and I've recognized that boundaries evolve, but just being aware that that's a thing. And then the other part of boundary setting is self-care. I think that we can't talk about making sure that you have boundaries without including self-care and making sure you take care of yourself. And, I personally really have, I think therapy has definitely helped me with that, understanding that I need time for myself. So when I am sick, I literally had to cancel cases last week because I think I was going to die. I was so sick. And it was my husband that told me, okay, this is ridiculous. You can't get off the couch. You have to cancel, right? But again, this is a recognition, and it's a constant evolving concept that even till today, sometimes I'm good and sometimes I'm not so good. So recognizing that self-care, happy you is a better surgeon. And you actually, when you establish these boundaries, you're actually creating a better version of yourself. And that better version of yourself takes better care of patients. So, kind of recognizing that. And no is a complete sentence.
I think there's transparency, right? In saying I'm human. And we always say work-life balance. I don't think it's ever balanced, like both sides are ever even. I think, like you said, you sometimes have, hey, for the next 2 years, 3 years, 6 months, 1 month, I'm really gonna have to grind down because I want to achieve XYZ thing at work. But
Absolutely.
when that's done, I'm going to prioritize these things with my family. And now it's going to shift. It's going to be a seesaw and not a balance. And I'm going to make sure that they're given overall equal time, but that the important things in both buckets get done with the right amount of attention. And, I will admit, first, I was not very good at that in my fellowship time in my first year of marriage here. And I'm working on it and we're getting better, but it involves those conversations. It involves conversations with partners, with family, with our colleagues at work, and sort of helping us set those boundaries and helping us set the priorities as well.
These were all great points. And I would say, as someone who, again, doesn't consider herself a early career surgeon, I learned a lot from the three of you. So I want to thank you for your honesty and transparency. I think there was a lot of real emotion and real life experience that I think anyone can take back with them. We are going to transition to the live Q&A, and it looks like we maybe have one question coming in. So the question is to the group: how do you change the tide of being burned out? I can say I personally experienced this as someone who took over a 12-year, very busy, very mature practice. Being thrown in and seeing a full panel of patients in 6 weeks is not how we always envision our career starting out, as a personal example. So when you get sort of overwhelmed and feel like you're not in control of your life and you're just dragging yourself to wake up and work the next day, how do you try to, undo that tide? Maybe we'll start with Tiffany on this one.
Sure. I mean, I think it goes back to what we have. Sorry, my cat has decided he's walking around meowing. So if you hear that, I think it goes back to what we said about setting boundaries. Is the thing, I think one of the greatest contributors to burnout is not setting boundaries, is overextending yourself, is doing more than you're capable of handling. And that it can span so many things. It's not just about time and the time you spend at work versus the time that you spend with your family. It's also the content of what you're doing at work. So for me, I realized after starting practice, I actually don't like general surgery. I do breast and endocrine. I just want to do those things. I do not want to be doing appendectomies in the middle of the night. And that was the thing that was making me the most unhappy in my job. And just kind of recognizing that and realizing that my first job wasn't my right job. It wasn't my forever job. And that I needed to course correct a little bit to figure out what my practice would look like that would make me happy and support my future for the next, not just, 6 months or a year, but 10, 20, 30 years as I progressed on my career. And I had to find a new job 2.5 years after my first job. But it was really recognizing what truly was going to make me happy, and having a firm boundary for myself, think I'm not going to continue in the job that is not the job that I want. And sometimes it's really hard to make those sorts of moves, but trust in yourself and just, talk to your family, talk to your partners, and figure out what that means for you.
Irlna, any thoughts? And then Cassie?
I think it's important to figure out why you're being burnt out, to be able to kind of figure out how to handle your burnt out. I think when I started my first job, I was burnt out at some point because I was feeling devalued. I wasn't feeling like my career was going where I wanted it to go. And I think it was chipping away at my surgical skill confidence. And I had to have a hard conversation with myself and recognize that if you continue this path, you're just not going to trust yourself and you're not going to be the surgeon that you're going to be. And that's a hard conversation to have. And because it was in an academic institution, and I've always thought that I wanted to be a program director. That was my dream when I was a resident. So it was a really hard pill for me to swallow, that this was not the right setting for me. But it was really getting to the point where I was not happy going to work. So that's contributed to my burnout. So I made the move to try private practice, and I've been really happy there. The other thing is, you can be burned out because of that. The other thing of burnt out is the workload, right? So I'm in a busy colorectal practice. And as a private practitioner or a private practice surgeon, busy practice kind of matters, right? I'm not in an academic situation. I don't have the coziness of, your RVUs may or may not be, important in this case, right? But at the same time, recognizing that as you're busy, you have to figure out what's important for you. Just a little quick story. My oldest daughter was graduating kindergarten. And that day I decided to do cases in the morning. Her graduation was at 10 o'clock. So I booked 7:30 cases at 7:30 till about 9 o'clock. That was my plan. And I was going to go to the graduation, and then after the graduation, do cases after. So I had fit my daughter's graduation into this operative day. I ended up missing it, and it crushed me. I mean, it made me so sad, because she's never going to graduate kindergarten again. I wasn't there for her graduation of kindergarten. That really taught me that is too important for me. That's going to end up actually impacting me more if I don't prioritize some of those things. So from now, at the beginning of the year, I tell my scheduler, my kids' birthdays are off. I'm off. That's not even a question. My kids' graduation, I'm off. Like, I don't even sort of have a conversation about that. So, that for me was that boundary that helped protect me and help my self-care so that I wouldn't get burnt out about certain things. So figuring out why you're getting burnt out, and then figuring out ways to really just, go around it, and having these hard conversations with yourself, I think is the best way.
Cassie, any other?
Yeah, I mean, I highlight the figuring out why, and I sit down and make a crummy list is what I call it. And I say, what is frustrating me? Why do I think I'm feeling this feeling? And you'll list out 5 or 6 things, and make sure you always follow it later in the day with a gratitude list. Otherwise it sort of sit in a negative space for too long. It's like the Californian in me, but when you look at what's on that list, then put it into buckets. Is this something that it's due to? Is this something I can get better because if I had resources? And if so, how can I get those resources? So if it's something related to the workplace and we're always short, or it has to do with billing and coding, or frustrations with lack of OR time, like, write down what it is so you can try to navigate that before it becomes a big blister, right? Find out why it's bothering you early, and then deal with it. If you're in the middle of burnout though, it's a hard place to be. And know that there's probably several others in your section department who have been there, and that you might need more resources if you're sitting in a place or in despair. And it might be that the job is not right for you. It might be that you're in the wrong external forces, relationship, or something else going on. But sometimes you do need that professional help. And I would encourage anyone who feels they need to talk through things to seek that mentor. If they don't have that mentor, to reach out to a trusted friend or family member. Make sure that you're taking care of what you need to take care of, and you are the most precious resource, right? No hospital, no operating room, no piece of technology is ever as good as you, the individual, the human. And you have to take care of yourself. And so if that means taking a step back, if it means having someone cover your call for a couple of days so you have a free weekend, please take the time you need. ACS has a whole well-being resources page, take care of that, utilize those resources. We can share that as well. But make sure, pulling yourself out sometimes, it's just adding a healthy routine back in. I started reading 20 minutes before I go to bed. It's something I really enjoyed doing all through college. As a kid, I would stay up reading past my bedtime all the time. I don't know when I lost it, but I lost it. And really recently, I had a mentor telling me all about these lovely books he's reading as he's nearing retirement. I'm going, man, if I could just do 20 minutes a night, and I am much happier now. And it's just that quiet time I was missing, and who knew I was missing it. So sometimes it's an easy fix, sometimes it's heavy lifting. Just make sure you take care of you as part of it.
I might just add a few things to piggyback on all the great things that have been said so far. Is in line with taking care of yourself is finding ways to delegate. I think we as women and surgeons take a lot on where others might delegate. And we feel we could do it faster, we could do it more efficiently. I won't have to follow up if I just do it myself. But if you do that with everything, that can definitely be a contributor of burnout. So I, probably 2.5 years in, asked for part-time use of an APP because my practice was overwhelming and I felt like I was in the middle of burnout, and I thought maybe I'm not going to get this, but I have to try and ask, and I got it. And it was a game changer. I think the other thing is taking vacation. When you are in a private practice and you're eat when you kill, or you have an RVU expectation, it can be really, or you just feel bad not seeing patients when patients are waiting. It can be really hard to say, I need a vacation. And I have learned to take the time off because I'm a better surgeon for my patients when I am not always working. I took 2 or 3 weeks off, I think in 2021, like during the pandemic, and I realized that was not enough time for me. So find the right amount of time for you and have those boundaries and block those times off so that you can work on yourself. Next question, I'm going to start with Cassie on this one is, how would you recommend to learn coding and billing best if it was not taught during residency? I think it's probably not taught in most residency groups. So what advice would you give?
It really isn't taught in most residency or fellowships. And then you end up sitting down your first week of attending and they go, here you go, sign a bunch of progress notes and assign in Epic your billing and all of that. And it is overwhelming. And I was really grateful. I had a partner who had started an Excel spreadsheet of the most common surgical billing codes that we use for our operations. Because in emergency surgery, trauma surgery, and critical care, there's never a standard operation. We don't do the same surgery 20,000 times. We do variations on many different things all the time. And so having all those different CPT codes listed out and when I could use them was very helpful. The other thing I'll point people to is the American College of Surgeons does have a billing and coding resources page. They have some courses that they attach to Clinical Congress. I know this last Clinical Congress, I think there was an emergency general surgery specific one. A lot of surgical societies, I think SAGES or America's Hernia Society often will have some associated with their conferences as well, or sponsors of their conference will offer them. If you have the ability to take advantage of them, I really would recommend it because I personally know, even though I'm getting better, I am leaving a ton of stuff on the table every day, especially when I'm in the ICU. And I feel like, I just don't have the bandwidth some days with how complicated things can get to put all those codes on. And I know our billers and coders miss a ton of it. So, do the best you can, educate yourself, talk to your partners. They will be especially helpful. They can sometimes point you in the direction of a specific biller or coder in your department or in your section at the hospital, who then you can have a meeting with to help optimize. They can look maybe at your last, 10, 15 cases, patients, whatever it is, and tell you where you've missed things and do a detailed dive so you can look for your own pattern recognition going forward.
I am going to add just a little onto that, and then I'm going to pose the next question both to Tiffany and Irlna. I teach several courses on billing and coding, and I would say 2 things to add on to what Cassie said are to buy the yearly American Medical Association CPT professional book. It has every CPT code for every specialty across medicine, and it helps you understand what is out there to code for surgeries and procedures. I, as a urologist, often use plastics codes for a lot of what I do, and so it helps you understand what's even out there for, again, procedural and operative coding. And then establishing your relationship with your coder and periodically auditing your cases to see, I billed it X way. Is it being billed that way, or is it being billed Y, like a different way, and meeting then with your coder and saying, what's the difference here in how I'm viewing this versus you? I found a lot of, what Cassie mentioned, things being left on the table because coders and surgeons look at documentation differently, and how we perceive how we wrote something and how coders are perceiving it are two very different things. To Irlna and Tiffany, I am going to read out this question. So one of our audience members needs advice on how to navigate searching for a job locally when you know your first job will need to change. And this person goes on to say, I've spent my whole training career in academics and I'm looking at jobs now. I'm a little reticent leaving academics because it's all I know, even though I think it may be better for me. Do you have any thoughts or recommendations about making the decision to leave? Maybe the question could be, what do you recommend when you know you need to change your job, especially when you need to stay local? And what would you recommend when considering practice setting change, i.e. leaving academics to another setting?
I think both Dr. Trantchou and I have experience with this sort of similar transitions. I had various pathways. I also thought I wanted to be in academics. I graduated fellowship during the pandemic. It was very difficult to find a job during that time. Most universities were not hiring. I actually did locums for a while. And then when the job came up at Kaiser, I was like, this is a great opportunity. I will take that. And I didn't know if it would be my, forever job or my first job, but I think you can never really know what you're going to want before you start. I think that's the most important thing to keep in mind, is that even if you think it's going to be your forever job, that it meets every checkbox that you had, once you actually start, those things are going to evolve. So whatever expectations you have when you start, just know that they will change, and that is normal and expected, and even a good thing. So, when you are doing your job search, which is a whole other thing, but just knowing that your first job is really your opportunity to learn how to be a surgeon. And maybe you're lucky and you stay in that job forever, maybe you don't, but just sort of continually reevaluating, my cat again, I'm sorry, where you are and sort of what you want is important.
I think I would also add just figuring out why you want to change, right? So I think why you want to change from the first job. So, going to your first job, I mean, yes, like you were saying, Tiffany, it doesn't have to be a forever job. It can be a forever job. Either way, it's fine. But I think that as you evolve and as you try to figure out what exactly you want, that then starts to almost kind of sort itself out. So like I said, for me, it was because, when I started, that's why the importance of the first job is also key, because when you're starting, surrounding yourself with as many mentors and really learning how to be a surgeon is really what you're seeking. And that's what you're looking for. Once you've sort of like felt a little comfortable being a surgeon and taking care of people, then your desires really kind of start to kind of come around and start to really, declare themselves to you. And again, for me, I wanted to be a robotic colorectal surgeon. It was very important for me to develop that skill set, to be the person that will be, that like I needed to be that person. And I knew that that's where I wanted to take my practice. And once it got to a point where it was clear to me at my first job that I was not going to be able to do the robotic numbers that I needed to do to become an expert in the robotic surgery, then that's when I had to realize, well, you know what's important for you. This is what's important for you. So that helped me so that when I looked for my second job, then I knew the first thing I asked was, am I going to be able to have robotic time? How much robotic time am I going to have? How many cases am I going to be? And I think that that's what you really learn as to what is important for you when you're looking for that second job. The first job, I think when you're looking for your first job, especially if you're looking locally, the location matters, and location is absolutely important. But as you want to start as a surgeon, I think starting surgery, the first 2 years are just sort of set the tone, I think, for your career as a surgeon, or at least for your mid surgical career, or how comfortable you're going to be. So starting off, you have to create a bucket of what's important, what's going to affect the growth of my surgical career, and what do I like, right? Because you're not going to get everything in your first job. Actually, any job, you're really not going to get everything. But recognizing that in your first job, what is really important is being in a setting where you're not going to be made fun of, you're not going to have malignant colleagues, you're going to have people that surround you and support you and allow you to grow as a surgeon is maybe more important than the location. So that way you need to sacrifice the location. So when you're moving for your second job, if that becomes a place, then you can put the location back in the bucket of, you know what, this is a necessity because I need to move close to my family, X, Y, and Z. So first identifying why you want to move from, one job to the other. I think it's incredibly important for you to be able to answer that question to yourself.
Thank you both. So seems we have 2 more questions that we're going to try to fit in before we wrap up. And I'm not sure we can have all 3 of you answer each question. So I'll just maybe have 1 or 2 of you, whoever gets to it first, for this next question. Any advice on how to navigate maternity decisions as you start in your first job? And this is a really large question that we could probably spend a whole separate panel on discussing. So I know, since it is so large, maybe just pick out one small facet that you feel like, is really important to you, that you feel like, maybe would be good to pass on.
There's no good time to have kids. It will suck either way. So not suck, but it'll be challenging either way. It'll be challenging as a resident. It'll be challenging as a fellow. It'll be challenging as a new surgeon. When I started my first job, I was pregnant with my twin daughters. And at the interview, when I started, I think I was like maybe 4 or 5 months pregnant. So I literally went on maternity leave like within the first year of my practice. And it was very challenging, right? Because I was afraid that I was going to lose my skill set. I was trying to take care of my twin daughters when I have a toddler at home. I was afraid that my colleagues or my partners were going to think I'm a slacker, because you think all these things, right? And, recognizing though that what's important is that you want to bring your family is important just as much as your career. So I was fortunate to have partners that really understood that, gave me the grace and gave me the opportunity to be a mother, be comfortable with being a mother. So when I came back, it wasn't used as a weapon against me. So I really appreciated that. And when I came back, setting different boundaries, that's where the evolution of boundaries started for me. So I needed to breastfeed and I needed to pump. So as I needed to pump, I had a disclaimer on my door in my office, and I'm sorry for the TMI, but these are real things. I had a thing on my office door that said, if the door is locked, you may not want to walk in. I had an administrator walk in one day in my office and I was pumping. He was like, "Oh my God, I'm so sorry." I was like, "It's okay." But just so you know, these are the boundaries that we're establishing, but not making it weird and bringing everybody along and recognizing things are changing now. I'm a mom. So during a surgery when I'm pregnant with my twin daughters, when I was doing a case, I remember doing a 10-hour pouch case when I was pregnant with my daughters, and I had to step in multiple times to go to the bathroom. I had my scrub tech or my nurse get me like a cool towel because I get hot. When you come back, if you need to pump, and all these things are things that you need to make sure that you voice, so everybody's aware and you make them a priority, just like taking care of the patient is a priority.
Thank you for that. I think based on time, we're going to move on to that last question, which I'll hope that Cassie and or Tiffany can chime in on. And the question is, what do you think of professional coaching? I think this is a topic that's been more visible and talked about probably in the last 3 to 5 years than it was before then. And if you have any direct experience or you've heard from others about how this has helped their career, could you share some of those thoughts?
Yeah, I'll say I tried a free coaching session that our Stanford sort of wellness thing offers. And I don't know that I got from it as much. It wasn't like surgical skills coaching. It wasn't someone in the OR. It was more of just a general like coaching leadership type situation. And it was helpful, but I think I didn't get as much out of it as I could have because I didn't know what it was about and what I wanted from it. And so I think if you're going to look for any of these resources, especially if you're going to pay for them, know what they can actually provide and within what criteria. Is it a professional surgical coach? Are they coming to help you with skills coaching or coaching for case management or to help you in your practice? If you're, say, private practice, you're trying to find efficiencies, know what it is that they can actually provide and reflect a lot on what it is you feel you actually need before you start that encounter and start paying for it. Because you want to make sure that those two things align so you can get out of it what you want. I have not had any experience with a professional surgical coach or anything like that, but I do know of people who have used them within practices to help with efficiencies, and they found their experience valuable. But it's not really something I'm familiar with being in more of my academic setting, but definitely know what you want out of it before you start engaging in it.
Tiffany, any thoughts?
Even outside of professional coaching, I think it's not something that I personally have had experience with, but even just sort of the informal peer support that you may have at your institution. I think if you don't have the finances to pay for professional coaching, or that's not something that is necessarily available where you work, that whatever sort of informal mentorship or peer support is, a reasonable substitute. And I just wanted to say one thing about the maternity question that I like to advocate for is if you are considering delaying until after training, egg freezing is something that is available as an option. It's very expensive, but I think it's something a lot of people don't know about and aren't considering, and is definitely an important option for people who may not be ready to have kids while you're working so much.
Thank you, Tiffany, for that. I actually know a urologist who did freeze her eggs during residency, knowing that wasn't the right time for her, and is now looking, a few years into practice to start a family. And I think she's really comforted by the fact that she made those decisions sort of earlier on in her medical career that will help her out now. And to the coaching question, while I haven't done it either, I do have some close colleagues who have, and I think that one of the pieces of advice that they've given, which I'll use if I ever go down that road, is to understand the difference between coaching and therapy. And I think some people who go into coaching don't know the difference. And sometimes their coaches state, I'm your coach, not your therapist, because there is a difference. And I think it's helpful to understand that difference and maybe ask sort of as you're interviewing coaches, is this something you can help me with? Or is this something more that a therapist could help me with? Or maybe you need both, but there is a difference. So just to consider that.
Can I just like one last little tidbit, because I have a professional coach and I absolutely adore her. I think that, I sought a professional coach, and I think that it goes back to what you said, Cassie, which is, why are you seeking the professional coach? Because I didn't know the difference. I didn't know what a surgical coach would bring me. I found someone in the colorectal surgical world, one of the greats of the colorectal surgical world. And I think having a coach has really, really been helpful in setting my mind correct, to really allow me to figure out what's important for myself, how to set boundaries, how to negotiate my contract, how to focus on what's important in my career, where do I want my career to go? Really, these conversations that you don't necessarily always have with yourself, and sometimes you don't know how to navigate and how to get to. She really kind of also helps me identify when I am feeling burnt out and I can't even see it. So as someone that has a professional coach and that didn't believe in it at all, I think it's an incredible resource, but the right coach is key.
Thank you. Thank you, Tiffany, for sort of interrupting and wanting to add more about the maternity question. And thank you, Irlna, for chiming in and adding more about coaching, because I think all of those are super important points. We are at the end of the webinar. I want to thank Cassie, Irlna, and Tiffany for spending the time with us today and